Yes, certainly. Okay, good morning, everyone. Apologies for the tardy starting time. So today we're going to be looking at cancer, the past, the present, and the future. Next slide, please. So cancer is an ancient disease. It's been around from the time of the dinosaurs. Before hominids were walking the earth, there was evidence of cancer in bone fossils with bone sarcomas. In ancient Egypt, between 1600 BC and 2500 BC, there was evidence of a papyrus scroll which showed patients with breast cancer, and the treatment was none. Hippocrates in 370 BC described cancer as a local growing invasive disorder, and he called it karkinos, which is Greek for crab. The reason being it looked like a crab crawling on the side. There's evidence of cancer in Peruvian and Chinese mummies, as well as Persian queens' skeletal remains. Medical oncology is a young specialty. It's 74 years old. This is just an image of breast cancer. It's called the Edwin Smith Papyrus. It shows that breast cancer was around in ancient Egypt, and there was no treatment for it at the time, except surgical excision, which was very equipped at the time. Next slide. So during the times of the dinosaurs, we found multiple dinosaurs with osteosarcomas in the fossils. So we can go to the next slide. So the fossils, you could see there was normal bone as well as malignant bone disease. Next slide. So from the beginning of when man walked the earth, from Australopithecus right up to Homo sapiens, there was cancer. And with a Homo sapien, what's in each of our hominids' hands is basically that their life was run around. And as you can see, our life, our phone, we are slaves to our phone. Next slide. This is just a mummy from Peru showing the remains of malignant melanoma. And these are just the remains again. Next. So the cradle of humankind in 2016, one of our own, Dr. Edward John Oates from the university's anatomical anthropology site that found and carbon dated a fossil with evidence of osteosarcoma in an early hominid from 1.7 million years ago. And there are multiple hominid fossils from both Maropeng and Stadfontein caves with evidence of cancer. Next slide. So prior to the 1900s, there was only surgery and surgery alone for treatment, and it was a very primitive form of surgery. So, for example, breast surgery. This is a painting done during the 1890s of a Dutch surgeon showing how a radical mastectomy was performed. Next slide. So it just showed how radical it was. And if you look at them, it's actually quite barbaric, and the outcomes of the patients were dismal. Next. Okay, this is the William Halsted. William Halsted was a general surgeon at Memorial Sloan Kettering. In 1882, he developed the first radical mastectomy with removal of the breast tissue, the pectoralis major, the minor, as well as a radical lymph node dissection, and basically cauterized the whole chest and left his patient defigured. Breast cancer was seen as a local disease, and the hypothesis was if you could remove that disease, you could treat it with surgery. So the procedure was named the Halsted mastectomy, and it remained the standard of care for almost a century. Later on, surgeons modified his radical mastectomy, and we eventually got better outcomes. And further on in the the slideshow, I'll talk about Fisher and how he showed that the lumpectomy and sentinel lymph node were superior to the radical mastectomy. Next slide. In 1891, immunotherapy was first used to treat cancer. William Coley was a surgeon from Memorial Sloan Kettering, pioneering the first non-surgical treatment of cancer through an early form of immunotherapy. He used the body's natural defense mechanisms to treat sarcoma with toxins of a bacterial skin infection. In 1895, Wilhelm Röntgen developed X-rays, and then in 1898, Marie and Pierre Curie discovered radium. This was important because oncology, we can't practice what we do without imaging. In 1913, the foundation of mammography was laid, and in the late 1950s, mammography screening was initiated. And in 1966, the radiologist Strax showed that the effectiveness at reducing breast cancer deaths. In 1918, external beam radiation was developed and was used. And then we also need to remember there's a place for radiation in cancer as well, that it can cause cancer, remembering the World War II atrocities of Hiroshima and Nagasaki. You can continue. In 1982, Papandreou Nicolai invented the pap smear, and it's still used this day as a screening tool for cervical cancer. And in the first world country, we are moving now towards using HPV testing and nucleic acid testing. And then in 1937, Franklin D. Roosevelt signed the first National Cancer Act. And this was the first time that cancer research came to the forefront in medicine. The National Cancer Institute was established and clinical trials were put in place. And then in 1941, we had the birth of hormonal therapy with Huggins, discovering that both estrogen and testosterone, if they removed, they could, in a male, if they had prostate cancer, the cancer would regress. And in a female, the breast cancer would regress. And hormone blockade is still used in treating our prostate cancers today. So in 1947, this is Sidney Farber. He's an anatomical pathologist from America. He was at the hospital where he used to work. He used to do the rounds in the pediatric oncology unit, and he would do the autopsies on the patient. And he wanted to find a cure because he saw the devastation that caused. So he realized that steroids could be used to induce a reduction, but it wasn't an induce a remission, but it was not long-lived. And then he developed a drug called aminopterin, which was the first dihydrofolate reductase inhibitor, the predecessor of methotrexate. Next slide. So this is where it gets interesting and where our 74 years as medical oncology paternity begins. So in 1946, nitrogen mustard gas was developed as chemical warfare. And then it was realized we could treat Hodgkin's lymphoma with them, with the regimen called MOP. And then in 1949, the FDA approved nitrogen mustard for the treatment of cancer. And then in 1958, Emil Frey pioneered the combination chemotherapy in the first cancer remissions. I put cures in inverted commas because we know we don't get a cure with cancer. Our patients go into remission. These remissions were lasting in children with acute lymphoblastic leukemia. And they found out that combination chemotherapy, which they called magic bullets, and that combination of the 4 drugs was called VAMP, made up of vincristine, aminopterin, methotrexate, and prednisone. Next. In 1950, the link between smoking and lung cancer was confirmed, and in 1953, the complete response of a choriocarcinoma treated with methotrexate was reported. And in 1954, the first tobacco litigation against the cigarette companies came up, and then they continued for years and are still ongoing. In the 1960s, mammography trials were ongoing, and it's been proven it's effective in screening for breast cancer. Okay, so this is an image of the cell cycle, and it just shows all the drugs that develop, where they work in which part of the cell cycle. I just want you to take a picture in your mind of it, and as we move forward, I'll explain why later. Okay, so one of our first drugs we have is vincristine. Now, vincristine is a vinca alkaloid, and it comes from periwinkle, which is if any of you are into botany, it's a flower found in Madagascar. So the vinca alkaloids come from periwinkle, which are the purple flowers, and here is another variety of periwinkle, which is found in gardens today. Next. Okay, so now we have what we call the big three. When the platinum analogs came to the forefront, they changed treating cancer. The very first one, cisplatin, I call a swear word, and I think the nephrologists will agree with me, because when we give cisplatin, we are so scared because we can cause irreversible kidney failure and ototoxicity. So when giving it, we always like to say to the registrars, we prehydrate with 2 liters of fluid. And then the other analogs, carboplatin and oxaliplatin. Next slide. Okay, this is Watson and Crick. They hypothesized about the DNA double helix. And this is important because that's where we had double link cancer treatment. Then we move on to bone marrow transplantation. In 1956, the first bone marrow transplant between identical twins was done by Dr. Thomas. Then in 1968, Dr. Good performed the first successful bone marrow transplant from a genetically matched sibling. And then in 1973, the first bone marrow transplant from an unrelated donor was performed, leading us to the way to perform allografts, haplografts, and matched unrelated donor grafts, but all in keeping in mind that there is graft versus host disease. And when a patient does develop graft versus host disease, it can be deadly. Next. The link between viruses and cancer. So in 1957, Charlotte Friend, a virologist, discovers a virus that causes leukemia in mice. His work was seen as controversial because he said viruses can cause the cancer. And it's true, because Epstein-Barr virus has been found in Hodgkin's lymphoma. We know that HPV 16 and 18 cause cervical cancer, and we know that HTLV1 causes HTLV1 leukemia, as well as hepatitis B, which can cause hepatocellular carcinoma in the wrong lung. So modern tumor immunology. In 1959, Lloyd, he discovered that bacterial products could be boost in animals' immunity to cancer, to cure cancer. So mice were injected with weakened versions of BCG, which are resistant to growth of implanted tumors. In 1960, the Philadelphia chromosome was discovered, the 922 translocation, with the resulting from swapping of genetic material from 2 different chromosomes. This move creates a fusion gene, the BCR-ABL gene, which promotes proliferation of the malignant cell line. And in the 1980s, tamoxifen was FDA approved and used with raloxifene to prevent breast cancer in patients with ductal carcinoma in situ. And then in 1986, secondhand smoke was declared a carcinogen. And then we need to remember, with the 1960 work of the Philadelphia chromosome, in 2001, imatinib from the IRIS trial 1 and 2 changed the way we treated chronic myeloid leukemia. Up to 90% of our patients went into a deep major molecular response, and less than 5% of them would go on to develop acute myeloid leukemia and a blastic crisis. Okay, so this is Bernard Fisher. He's a surgeon from the United States of America, and he was a breast surgeon in the 1970s. And he said, "In God we trust, all others must have data." And this was because when he did his work, what he did was he compared a lumpectomy and sentinel lymph node dissection to the modified radical mastectomy. And he found that patients who had a lumpectomy and a sentinel lymph node dissection did much better than patients who had a radical mastectomy. And then he also found that if you added radiation They even did even better. As you can see, there were only 878 relapses in this graph, with a p-interval of less than 0.001. Next. So in this graph, you can see the disease-free survival comparing total mastectomy to a lumpectomy with irradiation. And the data speaks for itself. So then it became standard that if the tumor was small enough and the patient did not have clinical palpable glands, a lumpectomy with a sentinel lymph node dissection was an acceptable way to treat instead of having disfiguring surgery. Next. So this is what we call a Taxus yew. It's a tree that's normally found in England and in the North Pacific in America. And one of our drugs, well, namely two of them, paclitaxel and docetaxel, come from this tree. Currently, there's a shortage of both paclitaxel and docetaxel. Paclitaxel works in the mitotic phase and it works on the microtubules. And as I said, it's extracted from the Pacific yew tree. And then Susan Howard's discovered its mechanism of action. And then also in 1979, the tumor suppressor gene P53 is discovered. And we know that P53, if there's a mutation, there's prone to patients developing Li-Fraumeni syndrome, Lynch syndrome, and other malignancies which can have poor prognosis in the long run when treated. And any tumor with a P53 deletion, if they get radiation, they usually do poorly, and it's a contraindication to do CT scans and give radiotherapy. So one would follow them up with MRIs. Next slide. Okay, so when you come to oncology, we have things called regimens, and it's an alphabet soup. If you arrive there, it's like learning a new language. So one of the first regimens we used for breast cancer was FAC, and it was a common regimen from the 1960s until early 2000s. And then what happened was it fell out of favor because a 3-drug combination was caused to cause more toxicity and do the patient less. And then in the 2000s, we developed the AC2T combination, and as well as multiple other combinations. So this is just what alphabet soup in oncology means. Next slide. Okay, so with breast cancer, we have predictive and prognostic genomic assays. All of them are RNA based, and we only use them in ER and ER positive, HER2 negative tumors. And it's used to develop a recurrence risk on endocrine therapy alone, and guides us whether the patient actually needs chemotherapy. So we actually are able to come to a time where not everyone with breast cancer needs chemotherapy. And the assays are the OncoDX type, which checks 21 genes, and the mammoprint, and another one is the Prosigna. Okay, in 1971, Nixon signed the second National Cancer Act. But the reason he did that was he wanted to take away attention from the war in Vietnam. And then in 1974, the FDA approved DTIC for malignant melanoma stage 4. And we only had DTIC right until 2011. And then Obama, in his opening speech for his health budget, said that in the near future, he would want to say cancer was only a constellation of stars. But I think we're very far away from that yet. In 1981, the first cancer vaccine was approved. This is the hepatitis B vaccine, and it prevented chronic hepatitis infection, and it was the principal cause of hepatocellular carcinoma. And then in 1984, filgrastim, or commonly known as Neupogen, was shown to reduce the frequency and severity of infections in patients with cancer, and allowed us to give dose-dense regimens and not to wait between treatment times, so we could get patients into remission and to surgery faster. Then the HER2 new oncogene emerged as a target for HER2 3-positive breast cancer. And remember, 20 to 25% of all breast cancers are HER2 3-positive, and these patients are the ones that had a dismal outcome prior to the advent of trastuzumab. Okay, so this is a slide just to show that everything nowadays is all about molecular biology, physiology, and molecular oncology. If we can move ahead. Okay, so, molecular oncology is all about basic science and just grasping the concept, okay? So it goes back to your second year physiology. You're sitting with your guyton, and having a ligand that binds to your second messenger. And then you have cyclic AMP, and then the formation of ATP. And a lot of our pathways in cancers use this. So if you understand this concept, you know what's happening with the BRAF pathway in melanoma. You know what's happening in the EGFR pathway in melanoma. Next slide. Okay. So this slide just shows that there's the molecular oncology of breast cancer, and that there are multiple genes involved, the BRCA1 and BRCA2, then the BCL2 gene, which is important in preventing cellular apoptosis, and TP53 as well, which, next slide. In 1990, the FDA approved BCG for the treatment of bladder cancer, and to this day, it remains the primary treatment for non-invasive muscle bladder cancer. And then in 1992, paclitaxel eventually was FDA approved for breast cancer, and then later was used as well in a doublet regimen for treating lung cancer. Next slide. Okay, so part of oncology is antiemetics. Before 1991, if you talk to an oncologist or a nursing sister who worked before then, we only had metoclopramide, dexamethasone, and diazepam. And as patients would sit in the chemo lounge, they'd have these large bowls for emesis. But in 1991, that all changed with the invention of ondansetron. And in 2003, aprepitant came to the fore. And in 2016, we started using an atypical anti-psychiatric drug, olanzapine, for chemo-induced vomiting as well. Okay. In 1994, the BRCA1 gene was discovered, and that's the first cancer gene that predisposed to breast cancer. And in 1995, the BRCA2 gene was discovered. These breakthroughs confirmed the genetic basis of some malignancies. Then we move on to 1997, where rituximab is developed. And in 1998, the FDA approves trastuzumab. So now finally we have something to treat our HER2 positive breast cancers. And now we use it in both the adjuvant setting and the metastatic setting. And now we have antibody drug conjugates like trastuzumab and Tanzine from the Catherine trial. So Angelina Jolie, I'm sure you all know, had a BRCA mutation, and her mother passed away of breast cancer at a very young age, and she herself was a BRCA carrier. And this led the public with patients with breast cancer to start being tested for breast cancer. And if they were carriers, they actually took charge of their health by going and having prophylactic mastectomies and having prophylactic total abdominal hysterectomies and oophorectomies to prevent ovarian, endometrial, and breast cancer. Next slide. In 1996, we have the birth of immune checkpoint blockade therapy. Allison was the first to show that blocking a molecule on immune cells called the cytotoxic lymphocyte antigen 4 could cure cancer in mouse. And in 2004, FDA was approved to treat docetaxel for stage 4 prostate cancer. Prior to this, we didn't have much for stage 4 prostate cancer except radiotherapy, bisphosphonates, and hormonal blockade. It was a seminal trial. And in 2018, the Nobel Peace Prize was given to Dr. Allison and Tasuku for their work on immune checkpoint inhibition. And in 2002, the beginning of chimeric antigen receptor T-cell therapies was started. And we use it now to treat multiple hematological malignancies. Once patients have relapsed, we have CAR T-cell therapy. It's not available yet in South Africa, but hopefully will be soon. So what happens is we collect the patient's blood, we reprogram their T-cells, genetically modify them and multiply them. And then we infuse them back into the patient. One of the biggest side effects with this is a cytokine release form. And if we grade it a cytokine release form grade 3, the patient is hypoxic and hypotensive, and they require ICU. And then you'll get a call from the pharmacist because you've written up a script for tocilizumab for 800 milligrams. And then the pharmacist will say to you, doctor, it's 800,000. Don't you want to wait for Monday so the medical aid can approve it? And you say no, because the patient's going to die if they don't get it. Right, next slide. So in 2003, the Human Genome Project was completed, and we had identified the genome, which assisted us in further research in our cancer development. And then in 2006, the FDA approved the first HPV vaccine. And now we have a 9-valent HPV vaccine. Initially, we had a bivalent and then a quadrivalent, so things are getting better. And in 2009, stereotactic radiotherapy was developed, which allowed patients to have a single day of high-dose treatment for metastatic brain tumors instead of having a prolonged course of treatment that lasted weeks. And then in 2010, the first cancer treatment vaccine was approved for prostate cancer, which is Sipuleucel T. And in 2011, the approval of ipilimumab, first CTLA-4 inhibitor, changed the way we treated melanoma. Prior to this, we only had DTIC, and at the most, our patients had at the 7 to 12% response rate, whereas with ipilimumab, we saw disease progression, progression-free survival, and overall survival. And then you would have patients with stage 4 that would have a maintained response with no evidence of disease. And then we had the development of more TKIs, vemurafenib being the first BRAF inhibitor, and then followed by dabrafenib, and then added MEK inhibitors. The wave then still continued. So the next wave of checkpoint inhibitors were pembrolizumab and nivolumab. So we have multiple trials, and they're all numbered. And it makes studying for the exams a bit difficult, but you get used to it. And then multiple checkmate trials. And now Pembro and Nivo are both approved by the FDA for non-small cell lung cancer and Nivo for renal cell carcinoma. And then in 2017, the MSK Impact diagnostic toolkit was used, where we could test targetable mutations in tumors. And then what we would do is we would do next generation sequencing. And if there was a targetable mutation, we could hopefully treat the target. Next. Okay. So this is the alphabet soup of lung cancer. So what happens is in lung cancer, from 2004 till 2020, we had a rapid progression of what we could do for lung cancer. Prior to this, we only had platinum doublets, and then we eventually got EGFR blockers, HER2 blockers, RET blockers, and then if patients had PD-1 positive breast cancer, they were treated with immunotherapy as well. Next slide. Okay, so these drugs were game changers. Next. Okay, but the wave still continued, because what happens is for our breast cancer, we have CDK4 and 6 inhibitors. We have ribociclib, palbociclib, and abemaciclib. So patients with ER/PR positive breast cancer that have developed resistance to the hormonal blockade, we now have another line of therapy. And our PARP inhibitors are polyadipose ribose inhibitors, and we use them to treat BRCA positive patients who carry the gene, the germline mutation in either breast cancer as well as ovarian cancer. And now they are being used in pancreatic cancer as well as prostate cancer. In South Africa, in the public sector, what do we have? We still have good old-fashioned chemo, which we had in the 1990s, but we're doing our best, and one day, hopefully, we will get there. Next slide. Okay, so where are we now? Now we have what we call BiTEs. BiTEs are bispecific T-cell engagers, and we also have antibody drug conjugates, and there are on the market a slew of them. One of them is the Destiny. If you look up a name of a trial, and it's the Destiny trials, and it's the drug antibody conjugate trastuzumab deruxtecan, and we use it to treat breast cancer in the HER2 positive setting, the HER2 low setting, where there are now studies being done for non-small cell lung cancer as well as gastric cancer. But nothing's lost forever. with everything, there's resistance. Our cancer became resistant to our chemotherapy via GP portals, and now our antibody drug conjugates, even though they knew there's evidence that we be developing resistance. Next slide. Okay, this is just a slide for a bite. It's just to show that it's an antibody conjugate that's bispecific, and it's a T cell redirection mechanism, and then it brings the CD3 T cell to the tumor cell and allows for lysis of the cell. Next slide. Then this is again an antibody drug conjugate, just a molecular picture. So we have and then we have what they do, and we can continue. Okay, so what the antibody drug conjugates do, they deliver an antibody that connects the antigen to the cancer cell that deliver a drug. And the drug can be a top 2 inhibitor, and it delivers a payload. And then we're able to get more DNA damaging and a better targeted treatment therapy for our patients. Next. Okay, so this is just a quick summary, okay? So in 1977, we had the first anti-estrogen, which was tamoxifen, and then we had the discovery of P53, as well as HER2 in 1984, and then the tumor suppressor genes, as well as the approval for drugs like anastrozole, as well as monoclonal antibodies like rituximab and herceptin, trastuzumab, released in 1997. And then in 2000, we started looking at molecular profiling and looking at a more targetable side, treating the mutations. And then as well, we discovered our immunotherapy. And then now we're using it, immunotherapy with antibody drug conjugates. Next slide. We have come a long way, but we're still at the tip of the iceberg. In 74 years, if we could do that, imagine when we did in 100 years where we will be. But it all comes at a price, the expense of the drugs. One cycle of pembrolizumab costs 90,000 Rand, and only top-tier medical aids pay for that. So I can't look into the crystal ball and say what's going to happen next, but we can go on to the next slide, please. We do need to continue doing research. Basic science research is basically what got us where we are today. Molecular oncology research needs to continue, and we need to do clinical trials. Clinical trials are gold standard care. We're able to give patients in the public sector access to first world standard care. And we have a trial unit, and whenever we can, we try and put our patients onto a clinical trial because it gives them access to drugs that they normally would not have. And then just remember, our patients always come first and humanity comes first. Next. So I've discussed the past, the present, and the future of oncology, and it was just a brief summary. I don't think an hour of time did this topic justice, but it's just to show how far we've come in 74 years, and we still have a long way ahead of us. Thank you for your time, and apologies for the technical difficulties.